Welcome to AETCM. Today we'll be discussing the case of a 22-year-old female who's working as a web developer in Kochi, and she is a known case of cystic fibrosis with bilateral bronchiectasis. History of presenting illness. The patient came to ER with complaints of cough and difficulty to expectorate, associated with shortness of breath after each bout of cough since 3 days. She has no complaints of fever, sore throat, rhinorrhea, hemoptysis, chest pain, chest discomfort, palpitation. No complaints of night sweats, evening rise of temperature, orthopnea, fatigue. Past history, she has known case of cystic fibrosis. Genetic study done in June 2024 with bilateral bronchiectasis. She also has history of pulmonary TB, which was diagnosed in 2018. Bronchoscopy was done and AFB smear in BAL was positive. She completed 6 months of ATT, and after completion, repeat bronchoscopy was done. BAL AFB smear was negative. Treatment history, she is already on inhaled corticosteroids and long-term long-acting beta agonists, and she was also on azithromycin prophylaxis. Family history, no significant family history, born out of non-consanguineous marriage. Summary, the patient is a 22-year-old female who's known case of cystic fibrosis with bilateral bronchiectasis and history of old pulmonary TB. Currently presented with complaints of cough and difficulty to expectorate, associated with shortness of breath and mild chest discomfort since 3 days. Moving on to examination, she was conscious, oriented and febrile. She's thin-built and poorly nourished. No pallor, icterus, cyanosis, clubbing, edema.
What is the reason for poor nourishment in cystic fibrosis? What are the reasons?
There is pancreatic insufficiency happen.
Then.
So malnutrition.
Malnutrition, absorption of nutrients can be reduced.
Then there's loss of proteins.
Loss of protein. That is one of the major issue in most of the lung diseases, especially in cystic fibrosis. Okay. Chronic pancreatitis, how do they present? When you told malnourishment. Second thing.
Ileus.
It is the most common presentation of chronic pancreatitis. She told correctly there is no absorption of all these nutrients. Then steatorrhea. Diarrhea is one of the major issue for them. Steatorrhea.
Vitals, pulse rate, she had a pulse rate of 110 beats per minute, regular in rhythm. BP was 110/70 millimeters mercury. Respiratory rate 24 per minute. Saturation 98% in room air. Respiratory system examination. Upper respiratory tract, normal nasal mucosa, no septal deviation or nasal polyps, no paranasal tenderness, good oral hygiene, and no tonsils.
Why you are telling about paranasal tenderness?
Patients with cystic fibrosis can have chronic rhinosinusitis.
Sinusitis. So it's very common finding in most of these patients.
Yeah. Lower respiratory tract, on inspection, shape of chest appeared bilaterally symmetrical, no drooping of shoulder, trachea appeared to be central, apical impulse not visible, chest wall movements appeared equal on both sides, thoraco-abdominal respiration, no visible pulsations or dilated veins. On palpation, no local rise of temperature or tenderness. Trachea palpated to be central. Apex beat palpated at left fifth intercostal space, 1 centimeter medial to midclavicular line. Chest movement bilateral equal on all areas. She had a chest circumference of 31 centimeter with a chest expansion of 1 centimeter, 0.5 centimeter on each hemithorax.
So, is it normal or abnormal?
It's abnormal. It's decreased expansion. Spinoscapular distance was bilaterally equal. AP diameter of 11 centimeter and transverse diameter of 17 centimeter with an anteroposterior to transverse ratio of 1.5.
Okay.
1:1.5. Then tactile and vocal frequencies equal and resonant bilaterally. Percussion resonant note was heard bilaterally over all areas. Auscultation, bilateral air entry was present. She had coarse crepitations over left infrascapular area on inspiration and expiration. She also had mild bilateral wheeze, mostly on expiration.
Okay.
At the time of presentation, initial point of care showed total count of 18,000, neutrophil predominant. CRP was 0.1. 0.1. Then we had done an X-ray also, which showed right lower zone haziness and a previous right lower lobe cavity suggestive of previous TB.
Okay.
And bilateral cystic dilatations were noted.
Which all conditions you get lower lobe tuberculosis? It is unusual to get a lower lobe tuberculosis. Normally you get upper lobe. Which all conditions you can get lower lobe tuberculosis?
NTM, no. No. NTM.
You told now one condition, that is a
Cystic fibrosis.
Cystic fibrosis is one condition. Okay, then.
Other than that,
Normally when you are immune, like your immunity is normal, upper lobe tuberculosis is more common because there are some more aeration, more or less aeration. No? Upper lobe, more aeration. Okay, maybe that is a reason. So, but most of the patients you get tuberculosis on the upper lobe. But some patients you can see bilateral tuberculosis, lower lobe tuberculosis, everything is common. What are these conditions?
rather immunodeficient.
Immunodeficiency. So, any patient who is having immunodeficiency like malignancy, transplantation, HIV, chronic uncontrolled diabetes, all these patients you can get sometimes bilateral or lower lobe tuberculosis. All the normal immunity persons will have an predominantly upper lobe tuberculosis. But in children, again, you can get middle lobe tuberculosis. That is called as, what is that syndrome called as? Brooks syndrome. Okay.
We had done initial investigations, inflammatory markers, total CBC, sputum
CBC
studies.
told it is high. Point of care,
yes,
it is high.
We send sputum for studies.
Okay, and CRP is normal. So what do you think? In the emergency room, we highly depend on this type of point of care investigation. You are telling counts are very high, WBC counts are high, and CRP is normal.
Maybe she was on steroid.
Huh?
Steroid.
Patients on steroid, one condition. But whenever you do point of care investigation, that is a message. Whenever you do point of care investigation, there is a chance for error. That you all should remember. Whether it is ABG, CBC, CRP, there is a point, there is a chance of error in the point of care instrument. That we have to remember. That's why whenever we have doubt, we always send to lab. Okay. Whatever it is, counts are high. CRP is very low. Like he told, when the patient is on steroids, counts can be high because of steroids, and even CRP can be reduced because of steroid. Okay. So both are possible. Okay.
We initiated her on antibiotics.
No, what are the other investigation?
Then we sent her sputum for studies. Culture reports awaited.
Okay.
Sputum gram smear came back with gram-positive cocci.
So gram-positive cocci in cystic fibrosis, what do you suspect?
Staphylococcus.
So there is one organism which is very common in cystic fibrosis, Staphylococcus. Normally in other type of patient it is Streptococcus. But in a damaged lung, like cystic fibrosis or COPD, if it is gram-positive cocci, there is a high chance for Staphylococcus. Okay.
Then
any other bacteria you want to commonly occurring in Pseudomonas. So two important bacteria, both are dangerous. Staphylococcus and Pseudomonas, both are destructive bacteria in lung. Okay, so we have to be very careful. What is necrotizing pneumonia? What do you mean by necrotizing pneumonia? We already discussed, that's why I'm asking. Necrotizing pneumonia.
Caused by
necrotization of pneumonia. It is commonly caused by Pseudomonas and Staphylococcus. Okay. So these two type of pneumonia, predominantly they produce necrotizing pneumonia. They destroy the lung. Okay, that is a problem.
We initiated the patient on...
You tell other investigation, you might have done some other investigation like...
routine investigation,
everything is normal.
Studies.
Everything is normal.
Counts were found to be elevated. We started her on antibiotics, now they're in a decreasing trend.
What antibiotics? Should we give oxygen for this patient?
Right now, when she presented, she was not in type 1 respiratory. She didn't have hypoxia.
Okay.
And, ABG was within normal limit. So
Okay.
we just treated it as
So no need
LRT at
of
present.
oxygen. Okay. Then
In her present condition.
okay. No need of oxygen at present.
At
Then
present.
antibiotic. What
Antibiotic.
antibiotic you prefer?
Antibiotic.
It's an empiric treatment, and once you get the gram-positive cocci in your peripheral smear of sputum, what type of treatment you offer?
She was initiated on cefepime.
Cefepime, tazobactam. Cefepime.
Yes.
Okay.
And her counts was found to be decreasing.
Okay. What
so
is the
it
coverage of
continued on.
Cefepime? What class it is?
Fourth generation.
Fourth generation. What is the coverage of this
Gram positive.
gram negative and
Gram negative.
it covers mostly gram positive and gram negative, almost in similar manner. But if you take the third generation, it is predominantly gram negative, then some gram positive. But when it comes to like fourth generation, it is better than third generation. Okay.
Then we started her on nebulized bronchodilators,
Okay.
mucolytics,
What mucolytic you are?
N-acetylcysteine.
N-acetylcysteine.
And we gave saline nebulizations also.
What saline nebulizer?
3%.
3%.
Saline.
What are the conditions you use 3% saline as a nebulizer, nebulization solution?
When there is obstruction,
Tell few common conditions. All conditions you don't give 3% saline. No? One is bronchiectasis. Okay. Second is cystic fibrosis. Third one is in pediatric condition. Where you give 3% adrenaline nebulization, 3% and adrenaline. Okay. Crop. No. So these are the three important conditions we use 3% saline as a nebulizer. Okay. But whatever it is, when you are giving 3% saline, it contains high sodium. It reduces the secretion. Okay.
Then patient is improving symptomatically. Right now we are awaiting the culture reports to see if anything further is required. Then we can now, she's also started on high protein diet.
Okay. What was the albumin and protein? Is it low? Or
no, within normal limit.
Within normal limit. Okay.
Then we can discharge her on long term because she has recurrent exacerbations.
Okay.
So we
How do you prevent recurrent exacerbation? What are the problems she can develop?
Prophylactic antibiotic.
What prophylactic antibiotic
we
you
prefer azithromycin.
Azithromycin. What is the dose?
250 milligram or once daily, alternate days.
Alternate days. Which all other conditions you give azithromycin as an preventive?
Anything that causes chronic inflammation.
Any chronic lung infection nowadays, we are giving azithromycin 250 milligram alternate days indefinitely, at least for 6 months. Okay. What are the actions of azithromycin in lung?
It suppresses the infection and also anti-inflammatory
It's an anti-inflammatory with an antibiotic action. Okay, it has got post-antibiotic effect also. So you can give that for lung infections and lung inflammations. Okay.
Then inhaler.
What inhaler you give?
She was on Combihale FF, which is a combination of formoterol and budesonide.
Okay.
She was already on that.
What is the value of? What is the role of IgE levels in cystic fibrosis? IgE. Where will you use in IgE in pulmonology?
The ABPA.
ABPA is one of the important conditions where we use IgE as a marker.
Yes.
Okay, but it is also elevated in some of the allergic conditions also. Here, if the patient is having recurrent breathlessness, or if you suspect ABP associated with cystic fibrosis, you can do an IgE level. If IgE level is high,
IgE was done last admission was 200.
Okay, it is normal.
Within normal limits. So this time it was not repeated.
Okay. Role of steroids?
And
anti-inflammatory. Okay. What else you can try?
Mucolytics can be.
Okay.
Then chest physiotherapy is very important.
Okay. Any other inhaled antibiotic you can advise?
Tobramycin.
Okay. So tobramycin is used when there is infection of what type of organism? Tobramycin is used in infection of which organ? Pseudomonas. So when there is a Pseudomonas infection, tobramycin inhalation will be better. But if you, like you told, gram-positive cocci, then azithromycin will be more than enough. Okay. So that's why you started azithromycin. You didn't get Pseudomonas in culture. Okay. Now, what are the clinical findings? This patient, leave that apart. What are the common clinical condition of cystic fibrosis?
On presentation, a patient, there'll be recurrent respiratory
Start from the hair to down,
hair.
head to toe.
Sir, first of all, patient will be mostly malnourished.
Okay, malnourished, hypoproteinemia,
First example.
edema will be there. Okay,
Then
sinusitis. Head to toe means start from here. Sinusitis is one of the most common presentation of cystic fibrosis. Then lungs, you get bilateral bronchiectasis and cyst formation in the lungs, secretions, recurrent infection. Heart, any finding? Normally there is no much finding. Abdomen?
pancreatitis. Insufficiency is there,
Okay.
exocrine.
Pancreatitis, exocrine, both endocrine and exocrine can be there. One is absorption, like you told, delayed absorption of nutrients from the stomach, and diabetes also. Both are possible. Okay. Then, anything else? Anything else?
No sweat.
Huh?
Sweat.
Go down. What is there next? Down.
It can affect the genital.
What?
Mostly in males, it can cause decreased fertility.
Infertility is one of the most problem, both in male and female, it can produce infertility. So that is one of the most important problem of these patients. Most of them will not have any children. Okay, so that can also become an issue. Okay, then how do you investigate? How do you evaluate? What are the treatment options available in children?
Right now in India, there's no newborn screening as such, but in other countries, they do newborn screening, and if they are at risk of having cystic fibrosis, then they immediately do a genetic test.
Okay.
And here we do sweat chloride testing. We can do baseline.
Okay.
But if there is more than 60 millimoles of chloride in sweat, then it is suggestive of cystic fibrosis, and we can follow up with a genetic study.
Okay.
Right now over here, there are we mostly do supportive symptomatic management, but there are CFTR modulators available.
Okay.
Like ivacaftor and lumicaftor.
That has to be started much earlier. Otherwise, it will produce all damages in the lungs. There is no point in giving all these things. That has to be started. Okay. Anything else?
Chest physiotherapy.
Chest physiotherapy is very important. Okay. Why chest physiotherapy is important?
To drain the secretions.
Okay. So mucolytic, especially N-acetylcysteine and chest physiotherapy, preventive doses of azithromycin will help the patient. Okay. Anyway, the disease may progress slowly. Once the patient deteriorate completely, what other treatment options are available now?
Lung transplant is end state, when it's severely.
Lung and pancreas transplant can be done. How far it is successful, we don't know. Okay. Thank you.
Thank you.